I'm delighted to be here. And it's actually my daughter who's an ophthalmologist, and my son's a pathologist. And she was going to do tumors, but then I left Britain, came here, so she's doing inflammation instead, which is really a tough specialty. So I'm going to speak about quality of life because that's what it's all about. It's really important to understand your own feelings and for us to understand your feelings so that we can make the best out of everything. So I did a study, I've been doing a study for many years to determine visual function, ocular comfort, patients' worries, anxiety, depression, and well-being after enucleation or radiotherapy for uveal melanoma, comparing the two. We're horrified at the thought of losing an eye, but is it as bad as that? So I started this study around the year 2000 or so, and I performed it when I was still in Liverpool, and just started it and just kept going on and on and on. And eventually we had data on about 1,500 patients. And I'm very grateful to all those patients who completed those questionnaires so meticulously. So when they came to see me, they were invited to participate in the study, and if they agreed, they complete a questionnaire after 6 months. And then on the anniversary of their treatment, I had Nicola in the corner who sent out all the questionnaires, got them back, sent out reminders, got them back, computerized everything. And I'm lucky that I'm still collaborating with my friends in Liverpool, and they've allowed me to look at the data here. And I'm lucky that at UCSF, I've been given lots of help and lots of support to be able to do the statistical analysis. Bruce Cooper, the statistician, has really been extremely helpful with this. So, just to understand, in Britain, my first choice of treatment was plaque treatment, because patients didn't like to travel, and if they had a plaque, they came on Sunday, saw me on Monday, had the plaque on Tuesday, out on Friday, home on Saturday, end of story. Whereas a proton beam, they had to come back for the markers, the simulation, all that kind of thing. There were a few more visits. But if I couldn't treat with plaque satisfactorily, then I was able to give them proton beam. And that's why I lived in Liverpool, because there was proton beam in Liverpool. And then if I couldn't do that, then I did an eyeball resection or an endo resection. If that wasn't going to work, then they had the eye removed. So I was fortunate to have everything. But treatment of the tumor is only one aspect to achieving a quality of life. It's really important to give patients choice, as we've heard earlier on, someone mentioning very eloquently how she was not given a choice. Important for patients to understand all they need to know in order to make the right choice, and that's why this group is really, really valuable. And then you keep hearing about patients, as soon as they hear the word melanoma, their ears close and they don't hear another word. So important to give printed information. All my patients used to get a 70-page book. Audio recordings of the conversations. I've been doing that since 1991, giving patients recordings of the conversation, and then having information available online. And then really, really important is the emotional support, those critical minutes after you've had the bad news. You don't want to walk out into a corridor full of people. You want to have a quiet space just to yourself. And I had 4 nurses working just for my patients, who used to sit with the patient, give them encouragement, emotional support, and then when they were ready to leave, that's when they left. And I was very lucky to have a full-time psychologist just for me, or my patients. Although I learned so much from her, because every week we had a meeting, and she used to give us an anecdote, a lesson that we all needed to learn, and that was really valuable. And then we also had financial support for patients. We used to pay the travel expenses to come to the clinic and pay for a night at a hotel for them and an accompanying person, because many patients would not have afforded to come otherwise. I was very fortunate to have these things. And even over here, we have gas cards and we have support for babies, families with retinoblastoma. They've got to travel a long way once a month for years. And so we have that here as well. So it's comparing enucleation and radiotherapy is not as simple as that, because not all patients with radiotherapy get a fantastic result, as you know. This shows the chance of keeping the results in the patients who participated in the study after radiotherapy. Most patients with a plaque had a small tumor in a nice place, got a good visual result. Most patients with proton beam had a difficult tumor near the nerve, and so they were more likely to lose vision. Very few tumors came back. Less than 5% of patients had a recurrence. And that's because if I thought the risk was greater than that, they had the eye removed. Better a good enucleation than a bad radiotherapy. And for that reason, very few patients lost the eye if they tried to save it. The ones who did lose the eye were the ones who had a big tumor. They were told that, it's not likely to work, but they wanted to try anyway. And so there were a few patients who lost the eye. So we designed this questionnaire a long time ago, in 1990 or so. I was one of a group, a European ophthalmic oncology group, and 4 or 5 of us designed this questionnaire specifically for ocular tumors. And I'm going to summarize the results. It's important for you to understand the bar diagram on the left. White means that they didn't experience the symptom at all. Light gray, it was a little bit bothersome. Dark gray, a little bit more bothersome. And black means that they were troubled quite a lot by that. And on the right, you can see how that symptom changed over the years. The continuous line is enucleation, and the dashed line is radiotherapy. So, for instance, difficulty reading, very few patients had difficulty reading, and it didn't make any difference whether they had one treatment or another, because nearly all still had a good eye on the other side. So, here are the results regards to vision. Difficulty, I have difficulty reading myself. Difficulty driving in the daytime, not too common, but that was because many people stopped driving. And one of the reasons why I'm giving this talk is because I know that you're interested in having a registry and looking at patient-reported outcomes and quality of life, and I wouldn't like you to repeat the mistakes that we made years ago. So it's good to learn from our experience. Double vision looking sideways, more common if patients had 2 eyes. But strangely enough, some patients even had double vision when they had 1 eye. So either they didn't understand the question, or they had astigmatism or something like that. And then there's difficulty pouring drinks. Missing the glass or whatever. Now, I tell patients before their treatment that that's going to happen. And if it happens, they've got to decide from now not to let it bother them and just to laugh at it. Because you get patients who learn that lesson and they knock something over, it doesn't bother them. And you get other patients and they get extremely upset when that happens. It's all in the mind. If you can persuade yourself to react one way, you'll be much happier than if you don't. And then there's difficulty with stairs, difficulty walking in crowds, people bumping into you, especially after the eye is removed. So these are the problems, limited activities, and they're more common after removal of the eye. Then discomfort. Discharge happens more after removal of an eye, watery eye, but these things get better over time. I forgot to show you the graphs on the right side. A lot of symptoms improve over time after removing the eye, because patients get used to it and learn the tips and tricks. Whereas with radiation, the side effects take years to develop, and so the symptoms get worse over time. Pain in the eye, rare headaches, a bit more common after radiotherapy. Then there's this problem, worries about metastatic disease. It's quite high to start off with, and then it improves, and then gets worse again. I don't know why it gets worse again. Either because a long time ago we didn't do genetic testing, so patients are in limbo, or else as patients get older, they get more worried. Or else a strange thing is, I used to tell patients their chances of surviving 10 years, and the same as we speak about this amongst ourselves medics. But then there was a patient once who told me that, she was really upset because she felt she only had a few months to live because she had reached 9 years. And she was almost 10 years. So her time was up. So I learned the hard way that you have to tell patients that the chance of living at least 10 years. And then hopefully that curve will come straight again. And then there's worries about recurrence in the eye. Strangely enough, I found from this exercise that some patients are worried about tumor coming back in the eye when they don't even have an eye for tumor to come back in. So it's important to reinforce that and to see patients and to remind them, because perhaps they're thinking they might come back behind the eye, which almost never happens, and so on. So I learned a lot from this. And then there's worries about their appearance. Very few patients were worried about their appearance. But the Brits, they're not worried about their clothes or anything. So. Then there's anxiety and depression. Anxiety, more of, first it's very an anxious time, and then you get used to the idea, you overcome that. Also, as patients get older, they become less anxious. Whereas depression tended to get a bit worse over time. That's something that happens as we get older, perhaps, to some of us. Then there's a functional assessment of cancer that's widely used in different cancers. Physical well-being, few patients had problems with physical well-being. Emotional well-being was diminished more often than the other forms of well-being. Social well-being, not much of a problem, not much black there. Functional well-being, not too bad. And in summary, the well-being, if you look at there's little black, so there's good well-being, and the curves on the right show it's quite flat, which means it's good throughout. It doesn't get better or worse. In comparison with the normal adult American population, these results are the same as the average population. They're not worse. You'd imagine there's going to be worse. But we've got a great capacity to adapt, and most of us do so, and like that remain in the normal population. The same with the cancer population there. So, except there's a dip for emotional well-being. And what are the questions that test emotional well-being? Sadness, coping, fear of future illness, fear of metastasis. Those are the things that diminish emotional well-being. So this shows the results according to genetic testing. On the right, you've got monosomy 3, bad prognosis. On the left, disomy 3, like class 1, good prognosis. There's very little difference, barely statistically significant in emotional well-being between a good genetic result and a bad genetic result. Why is that? Same with fears of metastasis. There's a statistical significance, but we're people, not statistics. And there's not as much of a difference as you'd expect. So what this means is a lot of patients didn't believe us. We told them you've got a good prognosis, and they thought we're just being nice to them. And so we learned that it's not enough just to send a letter, congratulations, you've got a good prognosis. You've got to emphasize, re-emphasize that you've got a good prognosis, because otherwise the worst fears will come out. And this was despite having genetic testing. Look up on top, that dotted line on top. When we said that they're not going to get metastasis, they very, very rarely got metastasis. And then we had this test that looks at all the predictors to So to double check the results, so to speak, to confirm that what we were saying made sense. And they still didn't believe that. But it just means that you've got to interact the right way. There's a right way and wrong way of speaking to people, and perhaps you hadn't learned how to do so properly yet. But what does this slide say? Dice material. I can't see my slides here. Oh yes, there's the next one. So what about the patients who did not have genetic testing? They're the ones who had the lowest fear of metastasis, even better than the ones who had a good prognosis. Why is that? Should we stop doing genetic testing? Well, no, in actual fact, they had few fears because there was a small problem because they had very small tumors. That's why they didn't have genetic testing, because in those days we weren't able to biopsy small tumors. Because they had small tumors, they were very more optimistic. So it wasn't because they didn't have genetic testing, it was because they had small tumors. So the reason I'm saying this is that if you do this kind of study here, it's not enough just to look at quality of life. You've got to look at tumor size, risk factors, all these other kinds of things. So we learned a lot from this study, the ocular melanoma survey, with results from all over the United States. And one of the really interesting results is that very few patients regretted having a genetic test. They're the ones up in red. Whether they had a good result or a bad result, nearly all patients who participated in the study, several of you are probably here, were glad that they had their genetic test. Lots of ophthalmologists say, no, you don't want to do that. It's just going to upset everybody. But it doesn't work that way. And we've found with our quality of life studies back in Britain that a genetic result, good or bad, empowers patients to take control over the condition. And now there's early results showing that adjuvant therapy prolongs life, so it's really more and more important. And there's more genetic mutations being discovered, and so it's really important to keep doing this. And at UCSF, we're doing next generation sequencing, which gives results on 500 genes, and we're able to biopsy the smallest tumor, less than 1 millimeter thick. There you can see the hole where the biopsy was performed, less than 1 millimeter thick. But this is something that's changing over the years. Screening for metastasis really improves quality of life because if you get a good result, you know that nothing's going to happen for the next 6, 9, 12 months. Something's going to happen to all of us sooner or later. But when you have a liver scan and it's normal, then you're like the rest of us. Nothing's going to happen before Christmas. Nothing's going to happen before the next birthday. And that's really very, very valuable for lots of patients. But the test has to be convincing. Unfortunately, we still have a lot of patients getting the wrong tests, like palpation of the abdomen, blood tests, chest x-ray. Not very good. And this is something I copied from that textbook, which was published only in 2012, and it's a textbook that eye specialists are still using to learn how to treat eye conditions, including melanoma. So there's a serious misinformation occurring, and that's one thing that this group can do. It can condemn this kind of misinformation and improve matters. So it has to be liver imaging, if possible, avoiding radiotherapy. And all of this is, before we were told, there's not much point in screening because you can't do much anyway. But things are really changing by the day. There's this immunocore treatment developed in Oxford, England, and it's for the first time we've got dramatic resolution of liver tumors from uveal melanoma. Before it was just skin melanoma metastases that responded. Now we've got uveal melanoma metastases that are responding to this treatment. Extremely exciting, gives a lot of scope. So self-reported quality of life is a question that I designed, and there's about 10% of patients who say that they've got a poor quality of life. So I looked at those patients, and I also asked them a question whether the poor quality of life is due to their eye condition or to other conditions. And only 1 in 5 patients attributed a poor quality of life to their ocular condition. And the large majority of patients, it's got nothing to do with their eye, nothing to do with the melanoma, it's other things. What are the other things? Well, we asked them. Poor social support. That means not having people close to you, not to share your feelings, to give you comfort, to drive you to hospital and back again. All these kinds of things that make life really meaningful. Patients who are unemployed, patients with poor general health because of diabetes, bronchitis, all sorts of other things unrelated to their eye, that reduces quality of life. Treatment, no difference. So it's really important to know that if you're going to have to remove your eye one day, it's not half as bad as you imagine it's going to be. The thought of it is much worse than the reality. So what can we do about this? Psychological support. We're working with Jamie Cohen now, and one of the things she does is helps people to appreciate their assets, that they're still here, to appreciate what they enjoy, to ignore what they don't like. So many patients have told me that the melanoma was a really good learning experience, and they're really glad they had it in a strange kind of way, because now it's made them better people. They know what they like. They don't bother doing things they don't like anymore, and they appreciate everything that you all take for granted until we're in our 90s with 6 months to live. They appreciate things so much more than they would have otherwise, and that's vital. Then you've got to help yourself. Then there's people to help you to do your homework, find out about the support organizations. You can get lots of information about financial aspects, about speaking to your family, how to speak to children. And the fact that you're all here today means that you've already done that. You're doing that very well. So in summary, despite having more symptoms, patients who have an eye removed are not unhappy because of their eye. If they are more unhappy, it's because of other things. They tend to be older, they tend to be men, they tend to have less social support. Perhaps that's what the statistics show, sorry. I didn't have time to show you the numbers, but patients are more likely to need to have the eye removed if they're older and other things. So it's not the loss of the eye that's affecting quality of life, but it's a poor quality of life that's leading to self-neglect, delay in presenting with symptoms, and therefore less chance of saving the eye because there's been a longer delay. So it's quite complicated. So really important, ocular treatment is only a small aspect to care, only a small aspect of your quality of life. There's so many other things that are very much more important. Thank you very much.